Hi, I am Amanda Dunlop, and I am a nurse practitioner with the Ohio Health Epilepsy Clinic, and I work in the Epilepsy Clinic and Epilepsy Monitoring Unit at Riverside, and I'm here today to talk to you about seizure monitoring devices, seizure safety, and seizure rescue planning. And my only important disclosure today is that I am a speaker with the Neuralis Speaker Bureau. I speak for them about Valtoco, which is a rescue medication that we'll be talking about a little bit today. Our objectives today is to discuss why it is important to have a seizure rescue action plan, to discuss how to develop and implement a seizure rescue plan, discuss seizure safety devices, what devices are available, and including what rescue medication and rescue devices are available, and what the benefits of having a rescue and seizure action plan are. So what is a seizure emergency? A seizure emergency is a seizure that lasts longer than 5 minutes, and that's what the International League Against Epilepsy's latest definition of a seizure emergency is. Any prolonged seizure event, seizures that are closer together than usual, and that can be seizures that occur for adults, 2 or more seizures in a 24-hour period, or for sometimes in children, 3 or more seizure events in a 24-hour period. There are many different terms that are used for seizures that tend to occur together. Common terms are seizure clusters, acute repetitive seizures, episodes of frequent seizure activity, or any type of seizure events that are outside of the person's usual seizure activity can be considered a seizure emergency. The biggest risks for seizure emergencies are uncontrolled epilepsy. Another thing that we consider a seizure emergency is when the person does not return to baseline in between their seizure events. If the person has an injury during seizures, such as a head injury, broken bones, dislocations, common ones are shoulder dislocations. If there's any concern of choking or aspiration, if the person has a seizure that occurs in water. So about 3.5 million people in the U.S. currently have active epilepsy, and 56% of adults who currently are on seizure medication are still having active seizures. And about 5% of those people have episodes of frequent seizure activity or seizure clusters. So that's about 170,000 people. And so what's the risk of having seizure clusters or frequent episodes of seizure activity? The risks are that those can result in status epilepticus, or prolonged seizure events that are difficult to control, SUDEP, which is sudden unexpected death in epilepsy, injuries that, like we talked about before, orthopedic injuries such as broken bones, shoulder dislocations, oral injuries such as dental injuries, lost tooth, tongue lacerations, the financial burden associated with recurrent seizures such as ED admissions, hospital admissions, missed work, work restrictions that occur when you've had a breakthrough seizure. There's a huge emotional burden. Many patients who have recurrent seizures have a huge associated anxiety, worried about when will my next seizure occur, or will I have another seizure. 75 to 80% of people say that they're worried about if they're going to have another seizure, or when will they have their next seizure. There's a depression associated with having seizures, impaired memory, family strain, work restrictions, driving restrictions, travel restrictions, restrictions on vacation. There's a huge loss of independence associated with having ongoing seizures. So a big way to help improve the anxiety and all of those things is to have a plan that can be implemented if in the event of a person has a seizure. So what is a seizure action plan or response plan? Well, it's a plan that can be implemented in the event that the person has a seizure. It should be simple instructions that can be implemented at home, school, work, or in the medical setting. It should be simple that could be implemented in the medical setting or by non-medical personnel. And seizure action plans can result in quicker cessation of the seizure, so stopping the seizure earlier, result in fewer injuries, fewer ED visits, fewer hospitalizations, less financial burden by less hospital and emergency room charges, and reduce that emotional burden, less anxiety by just knowing that you know what to do when you're going to have a seizure. It reduces the anxiety for both the caregivers and for the patient. So there was a study done, a survey that was done in 2017 that looked at all patients that were having active seizures, and only 30% of adults reported that they had a seizure rescue plan. And of all the patients that were having seizures, only 31% of the patients reported that when they had a seizure, what they did was they went to the ED instead. And 40% of the caregivers, people taking care of patients, which was usually a family member, reported that what they did was they went to the ED when the person had a seizure. And only 20% of people reported that they had a rescue medication that they used when the person had a seizure. So what that tells us is most people don't have a good plan for what to do when they have a seizure, or they feel prepared for what to do when they have a seizure. So how do you develop an action plan? Well, the action plan should be developed with a person's care provider and the team. This should be something that's developed with the patient involved, the care and the person's healthcare provider and their care providers at home. It should be personalized based on the person's individualized needs and can be revised as needed. It should include what to look for. What do your individual seizures look like? Should discuss how to prevent injuries. It should include who your contact emergencies are. It should include if you have any emergency medications or devices, when and how to use them, and what type of first aid should be used, and when is your seizures considered an emergency and what to do in case of an emergency. There are seizure action plan templates available. There are templates available on epilepsy.com. You can also find templates for medication lists, seizure diaries, and other helpful links. And you can talk to your provider about there are many different templates available that you can talk to your provider about what type of template might be good for you. Here are some examples. The one on over here, it says seizure action plan that's the one on epilepsy.com, and I kind of filled it out here. It says John Doe here on the top with some examples on how to fill that out. So it says two types of examples of what that person's seizures would look like, when to call. It gives example of that patient's rescue medications and what they should do. On the other is example of this one was developed by a group of epilepsy care providers in the Columbus area. It's an acute seizure action plan. It's very nice here that it gives some pictures of what that person's seizures would look like and the care that should be provided. So we reference that later. But that's another example of an action plan that can be used. So next we're going to talk about some rescue monitoring devices. There are a lot of different options available. There's wearable devices, implanted devices, some pillows, logging devices, and diaries. When you're thinking about a device, some things to consider is cost. A lot of devices you have to pay the initial cost, but then there's also monitoring or subscription fees. You have to think about appearance. What does it look like? Is it visible? How effective is it? A lot of devices we have to think about, are there false alarms? Is it easy to use? Is there support available? Was the device created years ago and now there isn't really customer service available anymore? Is it comfortable? What other features does it have? And what's the social acceptance of the device? So I'm going to talk about some of the devices available. There are a lot of different devices available, but I kind of stuck to the devices that were most available in the US. This is InFit Monitor. This basically is a mattress alarm. It detects repetitive movements that you can set parameters. There's no age or weight restriction, so it can be used for children and adults. It's not considered a medical device. It's simple and easy to use. You simply put the pad under the mattress, you set your parameters, and then you set it up with Wi-Fi. It collects 3 years of data, and then you can buy a extended option to if you want to get data beyond that 3 years, and it's about $199. I did put the website on there for people who are interested, but when you're concerned about nocturnal or nighttime events, that's a good monitor, a good option to consider. It can alert your caregivers if you're worried that someone might be having a seizure at night. You can set the parameters so that it's not just alerting you about normal nighttime movements for what type of specific movements that you're looking for. So that's one option to consider. SAMI 3, it's another type of bed alarm. Again, it alerts you to abnormal movements. It's a camera that detects movement. It's set up so it wouldn't alert for normal tossing and turning, but and it can also make recordings that you can share with your doctor. So if you capture a seizure and you want to show that to your doctor, there's different packages. So you can purchase just the camera for $399, but then it has a whole package where it comes with the iPad and different cameras that goes up to $1498. You have to have Wi-Fi. It only works with Apple devices, and you have to have reliable Wi-Fi for this device. Then there's Night Watch. This is an armband that you wear at night, and it connects to a device. It detects movement also. So it detects, it can alert up to 5 emergency contacts. So you can set up to alert 5 different people. You have to charge it during the day, and then you wear it at night. It has a monthly subscription plus device cost, and it wasn't very easy for me to find what the actual device cost was. You had to submit your information online and contact them. But you can get the information online. Again, you have to have good internet connection to use this device. But you wear the wristband up on your upper arm. Embrace 2. This is an option that a lot of patients choose. I have quite a few of my patients that choose to use the Embrace watch. It's a wearable device. It looks much like other smart watches. It's wearable. It only detects tonic-clonic type seizures. So I think that's one of the things my patients also often ask about. So if they have focal seizures, it's only going to detect the bigger movements. It is FDA cleared for ages 6 and up. It has 48 hours of battery life. It's waterproof up to 3 feet. It pairs with a smartphone through Bluetooth. So you do have to have smartphone, and you do have to have subscription. The device cost, it starts at $249. There are different levels of device that you can buy, different watch bands that you can buy, and the monthly subscription fees start at $9.90 a month. They do have an option on their website where you can apply for insurance reimbursement. I don't know how well that has gone. I was actually talking to our social worker to see if she'd known any patients who were able to do that yet. So I don't know how well that process goes, but there is an option to try and get reimbursement if you, or try to get it through your HSA. But again, I've included their website, but that is a device that many people use. It does have options to, you can have heart rate monitor on it, you can do GPS. There's different options for how much monitoring you want depending on which subscription you want to purchase. So that's another option in it as well. Inspire Smart Monitoring. So this is another option with a smartwatch. It is actually an application that you download. You download the application onto your smartphone of choice. You can either use Samsung or Apple devices, and then you choose the smartwatch of your choice. And the app, you buy different package levels depending on your choice. Their package ranges from $10 to $50 depending on which package you choose and which type of device you choose. So if you have Android, it's $10 to $40 a month. For iOS or Apple, it's $15 to $50 a month. There is a $20 activation fee included as well. The packages range with just monitoring for repetitive shaking movements and alerting your emergency contacts to, you can have packages that have help buttons and alerts and GPS and heart rate monitoring for the gold and platinum level packages. So I put the website for that one as well. So there are several different options with that as well. So for users who already have a smartphone, smartwatch, and they're just looking to add some monitoring, that might be a good option as well. There's different levels and options that they can look into. Seize Alarm, this is another application that you can use. This is only available for users with an iPhone and an Apple Watch. You just download the application to your phone or watch, or you can have, what it does is it detects the repetitive movements or the falls, and it alerts the emergency contacts that you have programmed into your phone. There are, again, different levels. You can have it set where it just alerts your emergency contacts, or you can have it programmed where you also have a help button where you push the button and it alerts your emergency contacts as well. So you can just download the application onto your devices. Anti-suffocation pillows. These are not as big in the United States, but in the UK, there are a lot more options for these. They can be quite costly. The idea of anti-suffocation pillows are to help prevent SUDEP, or sudden unexpected death in epilepsy. They have a lattice pattern, so they have the idea is that they assist with better airflow, so that if the person ends up sleeping in a prone position or face down, they prevent them from restricting airflow due to their pillow or bed sheets while they're sleeping if they were to have a seizure event while sleeping. There isn't as much recent data to support that these necessarily help, and they're very costly. So it is an option to look into something like this. They're not as much available. There were quite a bit of options. There were some options on Amazon if this was something you were interested in looking into. Again, they're costly. They're not considered a medical device in the United States. But those are available as well. And that brings us to rescue medications. So our first available rescue medication is rectal diazepam. For anyone who's had seizures for a long time, rectal diazepam was probably the first rescue medication that's been available to them. It was approved in 1997, and it's available for patients ages 2 and up. There's a lot of variability in available dosings. It comes in a pre-filled syringe, and the pharmacist selects a dial to adjust the dosing. There are some limitations with rectal diazepam. It's a little bit more difficult to administer, especially during a seizure, because we have to get the patient in the appropriate position in order to administer. The patient has to be disrobed. We have to worry about getting all the medication in without the medication leaking. There's variable absorption. And there's a concern about it, social acceptance. If you're not in a private area, we have to worry about the embarrassment of the patient and things like that. But the medication did work, and that was our best option for the longest time. Our other options have been oral medications, and there's several options. medications that absorb either under the tongue, in the cheek, or medications that the patient did have to swallow. Concerns with that, again, is that there's variable absorption. We have to worry about patients drooling out the medications. You have to worry about choking. And we always have to worry, we always tell people not to place anything in the person's mouth while administering medications because there's risk of injury to either the person or the person administering the medication. During seizures, people can clench their jaw, they can bite, they can choke. So that's why we always tell people not to put anything in the mouth during a seizure. So oral medications are usually not the best option for most types of seizures. And then again, the next option is IV or intramuscular medications. And these options work, but there's limited availability outside of the hospital setting. Most people don't have these options at home. And so those are a good option when you're in the right setting. And in the most recent years, we now have nasal rescue medications. There are 2 medications that are now available. There's nasal midazolam or niazolam and nasal diazepam or Valtoco. The nasal options are easy to administer. They come in little nasal inhalers that people are pretty well familiar with because other medications have been available through this route, such as Narcan or some nasal Imitrex. So people have been pretty well familiar with these medications the past few years. They're much more socially acceptable. The nose is much more accessible than other administration routes, such as rectal, during seizures. There's rapid absorption, so medications are much more quicker and easily absorbed during a seizure event. So the 2 options, they're pretty similar, and both are good options. There are a couple differences. Nasal midazolam or niazolam, it was approved in 2019, so just a couple years ago, for patients ages 12 and older. It comes in a 5 milligram dosing, and there are redosing instructions. The side effects are very similar for both medications. There's a little bit of variations, but most common side effects for these medications, we'll review them both. And then nasal diazepam's been approved for patients 6 and older, and then there are multiple weight-based dosing instructions based on patients' weight and age. You can redose if needed in 4 hours for all weight and ages. So side effects for both most medications, most commonly is some abnormal taste, abnormal smell, and mild somnolence, or mild being tired, and mild headache. So one thing to consider when we're thinking about rescue medications is rate of absorption. So IV medications get absorbed most rapidly. Within 30 to 60 seconds is onset of action with IV medication. So that's our quickest way to get a rescue medication to a person during a seizure. The next is intranasal. So our nasal medications, the nasal midazolam and nasal Valtoco. And then the next quickest is sublingual, which is absorbing in under the tongue, and that's 3 to 5 minutes. Again, there are some barriers with that because we have to worry about the patient drooling out some of the medication or choking. Intramuscular, which is the injection. Perirectal, like our Diastat or rectal diazepam. And then oral can take 30 to 90 minutes. So this is not ideal. You do see there's a big variation with the perirectal, 5 to 30 minutes for absorption time. And I didn't mention, I'll go back to this slide, if I can. With the nasal midazolam, I did want to mention, some patients may be familiar. Nasal midazolam has been used off-label for several years, actually. Prescribers have been using it off-label by using it with a syringe and a nasal optimizer. So some patients may be familiar with using it in that way. There are some barriers with that. What I've found is during a seizure event, caregivers are trying to get the syringe, the optimizer, put everything together. So the good thing with the difference between using the nasal midazolam with the optimizer versus using the pre-filled applicator is it's so much easier to use and administer, and there's less risk of losing medication during administration. Risk of error during administration is less than 1% with the new medications. So neuromodulation or implanted devices. So with VNS, I think it's important to include VNS as a rescue device and with our rescue plans. So if a patient has a VNS or a vagal nerve stimulator, this is an implanted device which is usually implanted on the patient's left chest, and I'll just go to the picture here. So it's implanted in the left chest, usually. Sometimes it's placed in the other options. So if we have a patient who tends to mess with their device, if they'll pick at the scar, sometimes the device will sit out a little bit. On very thin patients, sometimes the device protrudes a little bit and people will pick at the device. So they may place it in another location, like on the patient's back. So they may move the spot a little bit. And then there's a lead that goes up into the left vagus nerve there. And then, so the lead is placed on the left vagus nerve. It's been approved since 1997. And our most recent devices have several different modes. There's the standard mode, which delivers therapy at regular intervals to prevent seizures all the time. There's an auto-stimulation mode, which is set in response to elevated heart rates to detect potential seizures and respond. And then the magnet mode or response mode, which on-demand mode, which is set up as our rescue mode. So we program that so that the patient can use that to respond to breakthrough seizures. And so here's a demonstration of a person using their magnet to respond to activate their VNS in response to a seizure. So the VNS is used to help prevent seizures all the time, but then we program it so that they can also stimulate their VNS themselves as needed in response to a seizure event. Some of the barriers, of course, is it is a surgical procedure, so it has to be placed in surgery and then programmed by neurology. It usually takes several visits in order to achieve target dosing. So once the device isn't placed, it isn't set all the way at target dosing. It takes several months. There are some side effects, which include coughing, voice changes, and hoarseness. This varies. Sometimes patients get used to symptoms and they diminish with time. And some patients always have a little bit of side effects. There are risks with any surgery of potential surgery complications. Some patients have some shortness of breath with when their device goes off. And there are some restrictions with MRI depending on which device they have. So when you're ready to make your seizure action plan, it's important to make sure that you have access to the medications that you need, know where your medications are, and make sure you have your medications available. Know the names of your rescue medications and devices and how to use them. Know when and how to administer your medications, and know what to do when your medications or devices fail. Make sure that your caregivers know how to do seizure first aid. The most important thing to do is to stay calm during a seizure. Staying calm helps others to stay calm, and it helps the person having a seizure stay calm as they recover. It's important to stay with the person during a seizure until the seizure is over. It's important to time the seizure so that you know when to administer rescue medications and know when to call emergency help. It's important to prevent an injury. Remove any objects that could injure the person if they have a fall, or if the person is in a potentially dangerous situation, help steer them clear. Make sure that they don't guide towards water or something like walking towards traffic. Make sure that if they fall, that you help guide them so they don't potentially fall hit their head or fall onto any sharp objects. Don't hold the person down. Holding a person down isn't going to stop the injury, and you could potentially injure yourself or the person having a seizure. And it surprises me how often I still hear that someone has been told that they should put something in someone's mouth during a seizure. Don't put anything in a person's mouth during a seizure. People still sometimes have been told that they may swallow their tongue. No one is going to swallow their tongue during a seizure. Tongue lacerations are possible. People do bite their tongue. But if you put something in their mouth, they're more likely to bite it and injure their tongue, or bite something and swallow it, and they have risk of choking or having an injury from that. During a seizure, people frequently bite down and clench their jaw, and if you try to put something in their mouth, that's more likely to injure them, and you can get bitten during a seizure. So avoid putting anything in anybody's mouth during a seizure. Pay attention to the length of the seizure. Make sure you know when to implement the rescue plan and when to call for help. Do not give a person water, pills, or food until they're fully alert. After a seizure, people are often still altered and they may not know how to swallow correctly. And if you give them something to eat or drink too soon, they may get food or water into the lungs, which can cause aspiration. Make sure during a seizure event you try to keep onlookers away. During the seizure, you may need help, but after the seizure is under control, try and clear a crowd, which can avoid unnecessary embarrassment for the person having a seizure. Make sure you know when to call for help. If a seizure lasts more than 5 minutes, or if the person has 2 or more events, or if their seizure rescue medicines or device fail, call for help. If the person does not return to baseline or return to their normal self after their seizure event, if breathing becomes difficult, or if the person appears to be choking after the seizure, or if the seizure occurs in water, if a seizure may have occurred during the seizure, or if the person asks for medical help, that's when it's time to call for emergency help. Here's a list of some useful links. Epilepsy.com is a good website for seizure action plans, helpful forums, information about seizure first aid. I've listed all the websites for some of the seizure devices that we discussed today, the seizure rescue medicines we discussed today, and more information about VNS. And here are the references for the information that was reviewed today. I thank you all for joining my session today. I look forward to joining the question and answer session. And I hope you all enjoy the rest of the session and have a wonderful rest of your day.